Hello to all my students. Welcome in the 6th week in the second semester of your second year. I am Dr. Siham Al-Araj. I will be giving you the lecture about the oral mucous membrane, part 2. This lecture will give you a more clear view and more profound to the knowledge that was in the last lecture. I hope you will enjoy. So we will learn in this lecture the oral mucosa according to the sites: the lip, the buccal mucosa, the gingiva, the alveolar mucosa, the palate, the floor of the mouth, the tongue, and finally we will have some clinical considerations. So in the last lecture we have described the oral keratinized epithelium with some characteristics, as they firstly keratinize, which means they will become loaded with more keratin tonofilaments. They have intracellular junctions, notably tight desmosomes. They have mitotic activity and they divide continuously. They are of multiple layers and they do mature and differentiate as we go to the upper layer. We have desquamation or shedding of the last layer, uppermost layer, and it stains for the hematoxylin and eosine stain. They are derivatives from neural crest or the bone marrow. We have also described types of the oral mucosa according to the function. Firstly is the masticatory mucosa, which are of the 25% of areas that are subjected to masticatory and high friction forces. It is firm and rubbery in texture, which is composed of the hard palate and the attached gingiva as free marginal gingiva and the interdental papillae. This is mostly a keratinized epithelium. Secondly is the lining mucosa, composing most of the area of the membranes, oral membranes. It consists of non-keratinized epithelium and can be divided into the alveolar mucosa, the buccal mucosa, the soft palate, ventral surface of the tongue, floor of the mouth, and the lip. The third type according to the function is the specialized mucosa, which is different from the other two previous parts. It is composed of the vermilion zone of the lip, the junctional dentogingival epithelium, the dorsum of the tongue, and also the lymphoid tissue and the lingual tonsils. In this lecture, we will start with the lip. The lip has three sides: the skin side on the outer surface, the vermilion zone or the vermilion border, which is called also the transition or the red zone, and in the inner side is the labial or the oral mucosa. We see a striated muscle, the orbicularis oris, in the submucosa, and also some minor salivary glands. The skin of the lip is surely keratinized epidermis, and there is a connective tissue dermis. They mostly contain hair follicles, sebaceous glands, and sweat glands, as seen here in this slide. The vermilion zone has no skin appendages and no mucous glands. They occasionally have some sebaceous glands, but in some areas like the corners of the mouth. It is composed of keratinized, thin, translucent epithelium, which makes them more prominent in red color. The lamina propria has capillary loops and vessels. The intermediate zone is the junctional region between the vermilion zone and the labial mucosa. Mostly in infants it becomes thickened because of the suckling forces. This is composed of a parakeratinized epithelium. So moving from the skin, which is keratinized epithelium, to the vermilion zone, which is a specialized keratinized epithelium, to the transitional intermediate zone composed of parakeratinized, we reach to the labial mucosa, which is a non-keratinized thick epithelium. They have wide lamina propria with short irregular papillae. The submucosa has many salivary glands, which are called the labial glands, and there's a dense connective tissue fibers binding the mucosa to the orbicularis olus muscle. So these are the three parts of the lip: the skin outermost part, which we can distinguish through the appendages in the submucosa. Next is the vermilion zone, which we distinguish through the very thin keratinized epithelium and the presence of capillary loops. And thirdly is the mucous inner side, which is non-keratinized epithelium, and there's a mistake, it contains the labial glands. Moving to the buccal mucosa, which are the cheeks, they are non-keratinized lining epithelium, which means they have three layers: superficial, intermediate, and the basal layer. We have a submucosa with minor salivary glands and the buccinator muscle underneath. The gingiva is the portion of the oral mucosa which binds the tooth and it surrounds the teeth. So we have two main regions: either it is bound to an underlying bone or tooth, and therefore it's called attached gingiva, or it is not bound to neither a bone or tooth, which is called the free or the marginal gingiva. A free gingival groove is here, as you can see, in this area, which demarcates the free gingiva from the attached gingiva, and it's present in 40% of teeth. It comes at the junction between the level of the cement enamel junction. The attached gingiva, demarcated by the green arrows, are bound to the cementum of the tooth through principal fibers. The healthy gingiva normally shows some stippling corresponding to tall epithelial ridges and many numerous epithelial ridges. The interdental papilla fills the space in between the teeth. Markedly here is the mucogingival junction, which demarcates the attached gingiva from the alveolar mucosa. You can see the difference in color and the line is very clear. The external surface of the attached gingiva is composed of masticatory keratinized epithelium, but most of it is parakeratinized, which means there are some of the cells maintained. This makes the color is more toward light pinkish, masking the vascular lamina propria. The rete ridges have variations, and in the there is no submucosa. It is directly attached to mucoperiosteum. The free gingiva is identical to the attached gingiva, and normally we have a gingival sulcus. Here's the enamel space, here's the gingival sulcus reaching to the cemento enamel junction. Normally the gingival sulcus is 0.5 to 2 millimeters deep, and more than 3 millimeters it's called a periodontal pocket, which is an unhealthy condition. We can see the color, the alveolar mucosa, the attached gingiva, and the mucogingival junction in between. The dentogingival junction is the junction between the tooth and the gingiva. There's a gingival margin, which is the coronal limit of the free gingiva. The gingival sulcus, its unattached region between the gingiva and the tooth. And there's the junctional epithelium, which is where the gingiva is bound to the tooth. See the free gingiva, the attached gingiva, and the mucogingival junction marcating the alveolar mucosa down. Sometimes in some teeth we have the free gingival groove at the level of the cemento enamel junction. Both the sulcular and the junctional epithelia, they form the gingiva around the teeth. Both epithelia have different cytokeratin profiles. They are composed of a thin non-keratinized epithelium. To compare between both, the sulcular epithelium has more folded interface with the lamina propria. Compared to the junctional epithelium. So the junctional epithelium extends from the cemento enamel junction towards the gingival sulcus base. It is almost 2 millimeters. It is more thin apically, and it is composed of two main layers, the basal layer and the brachial cell layer. Also two basal lamina, an internal basal lamina and an external one in this side. Two layers doesn't mean it's just two layers of cells, but it is two types of cells. The junctional epithelium is a specialized non-keratinized epithelium. Firstly, it's derived from the same cytokeratin profile as the reduced enamel epithelium. Also, it is distinguished by its smooth connective tissue interface, so we don't have any papillae. A smaller number comparatively of desmosomes, which makes more space intracellularly, so that the clavicular or the sulcular fluid and the immune cells pass through the cells. We see here the external lamina, basal lamina, and the internal basal lamina composed of lucida, lamina lucida, and lamina densa, and the hemidesmosomes to attach the cells. This epithelium is characterized by the fastest turnover, reaching less than 7 days. So moving from the outer gingival epithelium, which is keratinized epithelium, to the sulcular epithelium, which is non-keratinized, and the junctional specialized thin epithelium, which binds to the tooth. We can see the gingival stippling made up by the epithelial ridges and the free gingival groove in some teeth. The interdental gingiva, which occupies the area between the adjacent teeth, has different shapes and sizes depending on the contact between two adjacent teeth. It can be wedge-shaped on the buccal and on the lingual sides, and for anterior teeth it is pointed, a pyramidal shape. The interdental coal is a curved depression across the plane which fills the contour. Here are two adjacent teeth and the interdental papillae pyramidal in shape. So the interdental papilla between two adjacent teeth is triangular, pyramidal in shape, would be pointed, and between bigger teeth like premolars and molars, it forms a caul. A caul is a slight depression between two mountains. And in our case, between two papillae, the proximal and the lingual papillae. The epithelium of the caul is continuous with the junctional epithelium. It is also non-keratinized, derived from reduced enamel epithelium. And spaced teeth have no caul. There will be no depression between the papillae. The dentogingival junction, as we said, it seals the lamina propria from the oral environment. The junctional epithelium has high permeability, which leads to passing of the gingival clavicular fluid, or what's called the gingival sulcular fluid. The material passes from the lamina propria into the tooth sulcus. It contains many polymorphonucleosides, and it's important for the defense mechanisms against bacteria and microorganisms. The lamina propria of the gingiva contains dense collagen bundles and principal fibers connecting the gingiva to the tooth, the alveolus, the periosteum, and it has many shapes like longitudinal, vertical, circular, semicircular, transgingival, and transseptal fibers. Moving to the alveolar mucosa, it lines the lower part of the alveolus from the facial side. It has a loose submucosa rich with elastin fibers for mobility, and it helps in speech. It has a submucosa which is attached to the periosteum. Of course, it's non-keratinized lining epithelium, and we have many blood vessels near the surface, which are obvious if you stretch your alveolar mucosa. Many salivary glands are also present. Here's the linkage between the gingiva, which is keratinized epithelium, and the alveolar non-keratinized epithelium. This is the mucogingival groove. Next is the hard palate. It is composed histologically of palatal gingiva, a midline raphe and incisive papillae, or rugae, which are here, and the two anterior lateral parts are composed of fatty zone, while the two posterolateral parts are glandular zone according to the composition of the submucosa. Histologically, we have epithelial ridges, which are tall, and this is the junction between the anterior fatty zone and the posterior glandular zone, composed of salivary glands. Again, it's a masticatory keratinized epithelium. In the central region, where we have a rugae or middle palatine raphe, we don't have any submucosa. It is a mucoperiosteum binding directly to the bone, while in the other parts we have submucosa, which binds the gingiva to the tooth. The epithelium to the bone. It contains mainly neurovascular bundles, minor salivary glands in the posterior region, glandular region, and adipose tissue in the anterior fatty region. The soft palate is a non-keratinized lining mucosa. It has, on the other hand, unlike the hard palate, a short, broad connective tissue papillae, as you can see. The submucosa is extremely thin, and it has fat and salivary gland. It has firm attachment to the underlying muscle, and it allows for speech and swallowing. The junction between the hard keratinized epithelium, the hard palate, and the non-keratinized epithelium, the soft palate, we can see little sensory organs like taste buds. The other side of the soft palate, the nasal side, is composed of the submucosa is composed of minor glands and capillaries, vascular submucosa. If we magnify more, we can see the respiratory epithelium, which are columnar cells that are ciliated, and goblet rounded cells. So the soft palate has two sides: the oral side, composed of keratinized epithelium, and the nasal side, composed of respiratory columnar ciliated epithelium. Here is the skeletal muscles, the minor salivary glands. We can see is also here the palatine tonsils and lymphoid tissue. The floor of the mouth, along with the ventral surface of the tongue, have a typical continuous lining mucosa composed of a thin, non-keratinized epithelium. The connective tissue or the lamina propria have short papillae, and the submucosa of the floor of the mouth has considerable thickness, while it is almost absent in the ventral surface of the tongue. In these two sites, we have high need for mobility, and we have highly vascular lamina propria, which is a main sublingual drug route. So the dorsal surface of the tongue, compared to the ventral thin non-keratinized epithelium, is a masticatory mucosa and has structures of specialized mucosa on it. The submucosa anteriorly is composed of the striated muscle and few adipose tissue, while moving posteriorly, we will have more adipose tissue and more minor salivary glands. The tongue is divided into anterior 2/3, which is covered mainly with papillae, and a posterior third, which is mostly made of lymphatic nodules. The divisions are divided with the sulcus terminalis. The tongue papilla consists of 4 parts, named according to their shape. So first is the filiform, which is fill or thread-like. Second is the fungiform, which has a mushroom-like. Third is the circumvallate, which is bordered, has raised edges. And fourth are the foliate papillae, which means they are leaf-like, like the leaves. All of these papillae have taste buds except the filiform papillae, which are only for friction. First is the filiform type. It is keratinized epithelium. It is most numerous type of papillae covering the anterior dorsum of the tongue. It does not contain any taste buds, but they function for the high abrasive forces. Their shape is cone shape with 2 papillae on the sides. Second, the fungiform papillae, looking like mushroom. They are big in size. They are keratinized or non-keratinized. Each contain 1 to 3 taste buds, demarcated here, and they have rich capillary in the lamina propria. Thirdly is the foliate papillae, which is located on the lateral side of the tongue. It is a non-keratinized epithelium and it contains taste buds within their epithelium. Next is the circumvallate papillae or the vallate papillae. They are large and have rich surrounding ridge or trench-like structure. They are composed of non-keratinized epithelium and they have numerous taste buds on the internal wall of their trenches. Minor salivary glands called von Ebner, they open in the trophy of the vallate papillae, emptying its secretions, which are rich in salivary lipase for food digestion. As a summary, these are the 4 types of tongue papillae, which have 4 different sites and 4 different forms. All of them contain the taste buds except the filiform papillae. So what are the taste buds? These are chemoreceptive organs responsible for the taste. They are situated within the 3 types of papillae mentioned before, in addition to the soft palate and the epiglottis. They have 2 main types of cells, the sensory cell and the supporting cell, and an outside pore which opens to the surface into the bud. So these intraepithelial organs are barrel in shape. They have an outer surface that's covered by flat epithelial cells, enclosing a very small pore, which is called the taste pore. It leads to a narrow space supported by supporting cells. The inner cells are spindle-shaped and the outer cells are more longitudinal. In between these cells, we have neuroepithelial cells, which are rich plexus of nerves binding underneath. Whenever the chemical binds or gets in contact with the nerve cells, the taste is stimulated. These taste buds had 4 sensory cell types, which are not very important. Lastly is the lingual tonsils, which are masses of lymphoid tissue found on the posterior border of the tongue. They are part of the whole Waldeyer's ring, which is the lingual, the palatine, the tubal, and the pharyngeal tonsils. This lymphoid tissue contains crypts lined with epithelium and have mucous glands. Finally is the most interesting part for me, which is the clinical considerations. Now, any change in the cytokeratin levels of the oral mucosal epithelial cells can be due to an inflammation, to a diagnostic histopathology, for example, neoplasms, it can indicate dysplastic changes, and it can determine the origin of the cysts. Interestingly, the mucosal wounds are rarely scar forming, especially the gingival wounds. They don't form any scars. So they, as we said, they are derived from mesenchymal origin, and they have a very high or fast turnover rate. To summarize the clinical considerations, I have represented on this diagram for easier classification. On the lining, masticatory, tongue, and the dentogingival junction. All of these oral manifestations have a histological background that you can take from the 2 lectures mentioned, namely the linea alba buccalis, ectopic sebaceous or fordyce granules, the leukoplakia, the nicotinic stomatitis on the palate. On the tongue are lingual papillitis, lingual thyroid, lingual fissures, lingual atrophy, black hairy tongue. Migratory glossitis, or if found other place, it's migratory stomatitis, oral mucositis, the lesions which are dysplastic or neoplastic. Finally, all manifestations of the gingiva, the redness, the hyperplasia, the recession, the bleeding, and also the periodontal pockets or periodontal abscess or cyst. From these clinical oral manifestations, you should be able to distinguish, firstly, which of these conditions are variations of normal, benign, or premalignant conditions. Secondly, how are these conditions manifested histologically, and which section of the histology that we studied is responsible for these oral manifestations. I thank you for your attention. I will provide you with the answers to your colleague. Goodbye.